Our first speaker today is Derek Beaton. Derek leads the Advanced Analytics team in Data Science and Advanced Analytics at Unity Health Toronto. Previously, he was a postdoc at the Rotman Research Institute at Baycrest Health Sciences and one of Ontario's neurodegenerative disease research initiatives scholars, the long phrase. His work focuses on multivariate methods, multimodal data, biostats, and neuroinformatics, and we're looking forward to his talk today. So please join us.
Thank you for this. Is this the button to make it go? Cool, okay, awesome. I'll start out by saying I have no disclosures or conflicts. And a little overview of the big picture of what I'm going to talk about today. I'll tell you a little bit about our team, the Data Science and Advanced Analytics team, how we do what we do, really the bedrock of how we get things done. Some of the lessons we've learned, which are hard lessons to be very frank, and then some of the bigger issues that we're facing that I think as the field moves forward are going to be critical for us to think of, because these problems are only going to get bigger, more complex as we move forward and deploy more things into practice. So, the Data Science and Advanced Analytics team, we're an applied healthcare data science unit in a healthcare system. We are in Unity Health. It is 3 hospitals. The hospital that we're based out of, St. Michael's, just down the street. We make tools for decision makers, clinicians, staff, nurses, HR, basically anybody who has a problem that needs to be solved with data. We build a tool for them from start to finish. So we build the data pipelines, the models, the front end, the software, whatever needs to be done, we do it. So the team is made up of 5 little sub-teams. We have the analytics team that I'm a part of. We do the modeling and statistical analyses. We have the data team, which is a data integration team, primarily data engineers. The support team, which is project management. None of this gets done without them. As well as clinical informatics specialists, a critical role to help connect informatics to what is actually happening on the ground. Product development team, which is primarily software development and human factors design, and a commercialization team, which is right now just one person, working very hard to help spin out what we do and make it go beyond our walls. This is a snapshot of what we've managed to do in the last 6 or so years. Each one of these dots, each one of these things here is one of the products that we've deployed. And these lines here are basically from the start to the launch. All of these you should kind of assume, and you'll see in a moment, really extend beyond the slide here. All of these, or most of these, are still maintained. So once we put something into production, you still got to keep it going. So how do we do this? The easy parts are actually like the software and the modeling. This is relatively solved. Engineering, stats, ML, this is not the hard part. The hard parts are understanding the problem. So did someone bring something to you that is feasible, doable, achievable, will have impact? Finding and actually understanding the data in the complex systems that we have, like the EPRs or PACS, like do these things actually exist? And it can be hard to translate what we actually see for real-time data or real data feeds, contrary to like research data. We need commitment. People have to be on board. So the way we structure all of our projects are people bring their problems to us and we work directly with them, and we set up a schedule. We work together every 2 weeks to make sure we get something out the door from start to finish, and this can be a very long process. Some products take couple years just to get out the door, and then we start the evaluation phase. So this is a very long time for everyone to be involved. And then operationalization, actually getting something finished and then into someone's hands, used and operating as an intervention is non-trivial. And this is why we have such a diverse team, and in particular now, clinical informatics specialists to help us understand clinical workflows. Now the bedrock of what we do and how we do this is a project intake form. And I'm not going to go through the whole thing, but and we're happy to share it too, because it's been very useful for a lot of folks. The project intake form will help us establish the team, so who on our team is involved, what stakeholders are involved in the hospital side, what leadership is required. The problem definition, current and future states, and the future state is important because it gives you a sense of what is the ideal product. Rarely do we ever actually hit that ideal product, but it at least gives us a signpost along the way And through agile development, we'll get there, or we'll get to some approximation of getting there. But it's really important that people understand and have a sense of what they actually want by the end of this. We do also require everyone to look into existing tools and literature, because if there's something better, different, or cheaper out there, let's go get that. We don't need to build something from scratch. And then the impact and risks. These are really, really important. We need to know what kind of risks patients might face, or users might have, or just risks to the adoption of using these things. So I'm going to focus for a moment on the impact of the tool, which really is how we help decide what we do and measure just how valuable these things are. This is a snippet of the intake form that covers the metrics we're expecting that you cover. And this is mortality, readmission, length of stay, something financial, human effort, or other. If an intake form comes to us with an other, we tend to just kind of put it aside. If you can't tell us one of the like kind of big markers to move, you kind of go off to a separate pile for a while. With things like mortality, readmission, length of stay, anything financial or human effort, this is also how we help prioritize. So if you think you're going to move a needle in any one of these, and we can see a lot of needles moving, then this goes a little higher in our list to work on. Now, importantly, when these come to us, we need to find the data that actually help us measure these things. If you think an intervention is going to reduce mortality, tell us by how much, and then also tell us what are the rates right now. If you think a tool would help you move the needle by about a relative 10%, are we at a 2% mortality rate or like 15? Something at a 2 would be hard to move. 15 is much easier. This actually sets the baseline of what to expect and how much impact we're going to see by the end of this. So after the intake, we will kick off. We begin. And this is a very idyllic version of the process. We go through these stages, we understand the problem, we kick things off and go into like a agile cycle of development until eventually we hit evaluation and maintenance. But really, it's kind of messy in parallel for all the good and bad. So a number of the different stages can be done independently or in parallel, in part because we have different teams operating on different things. So the data analytics team, advanced analytics team, can actually start in on exploration and modeling, while the product team, product development team, can start thinking about what interfaces might look like. And the data engineering team will start looking into what source systems we actually have to hook up to. So some of these things can be done in parallel, but frankly, contrary to the previous slide, it is a little bit messy to actually get this stuff done. So some of the lessons we've learned critically through deploying a number of products. The most important phases, and where you should spend the most time, or where we do spend the most time, is the very beginning and what I'm putting in quotes as the very end. So the feasibility assessment, the intake, this takes a very long time. And it helps us understand what is valuable. And if we can make it through an intake form together after sometimes months, we know that there's something here. This is kind of our triaging process. Now, the end here is something that is in quotes because it doesn't exist. Once you put something into production, everyone gets very happy, and we've launched, and we have a little celebration, and then the team needs to go back and maintain it. So there is an indefinite end to most, if not everything that we do right now, which is exceptionally difficult to think about when you're very excited in the beginning to do something new, fun, and cool. So that has actually informed us very recently on how we address sunsetting. When is it time to shut something off? This can be based off of usage statistics if people are no longer using these products. There are some examples of things that we've built before the pandemic that just don't have a role anymore. The landscape of healthcare and staffing and stuff have changed, so these tools just don't work the same anymore. They're not used the same anymore. We've also started to explore the idea of a shelf life or time limit. We don't have Windows 2000 anymore, and every so often we're told there's a new upgrade to whatever OS is coming, and you better get on board. So we are exploring the idea of setting time limits of when we restart or just have to put something away after a certain amount of time. The other very critical thing is you should monitor absolutely everything. With machine learning, we're used to monitoring data and models. But when you're putting things into production, it's the systems, it's the usage, and something here that I'll mention in the next slide, the intervention itself. So I want to put out there the idea of an intervention monitor. So a bit of background on one of our projects. The hemodialysis unplanned readmission risk tool is a tool that operates on patients to identify highest risk individuals for unplanned readmission. And these are patients that go to hemodialysis 3 times a week. They tend to have frequent return visits to the hospital, whether it's the emergency department or unplanned admissions to inpatient. And we deployed this tool and it worked very well. We saw about a 30% reduction in readmission rates over the course of a year. This was our first evaluation period from launch to the actual statistical evaluation. But we are monitoring this actual intervention. So the intent here is to bring down readmissions. Over time, a little bit after that 1-year mark, we see the readmission rates kind of creeping up a little bit. And we do know that the intervention involved here is fairly complex. It is hard on clinicians to actually keep this intervention in place. So we're monitoring this because it will help us identify whether this is a tool that is no longer working. And I'm actually going to bring this back. The hemodialysis project has come up 2 more times in this talk, and we'll see why. So there are some bigger issues after putting a lot of tools into production. And I'm not going to talk about any solutions today. We are doing things to try to address a number of these issues, but I want to put these out there as things for the field to really address. Importantly, there are a number of great works on this, and in fact, I think Mike Kalachi has a poster today on some of this. We'll see in a couple slides a topic on what you do with retraining data once you have an intervention. So part 2 of this hemodialysis unplanned readmission tool. If we do see the rates of unplanned admission return to baseline, we have a very difficult question or set of questions to ask that are both ethical and statistical. Do we stop this tool? If we stop this tool, was it actually still working? And are we going to make the readmission rates then jump even higher than the baseline? So we don't really know what the consequences would be if we stop this tool, even though we're monitoring the intervention to see that the rates are creeping up just a little bit. This is a really big challenge, and we don't know what to do. Whether something should stay on, and we keep the maintenance, keep our team maintaining this tool, or if it's time to take this tool offline. Both have risks associated with them. So now I'll tell us about one of our EPR prediction tools, ChartWatch. This is a deterioration tool. It's one of our flagships. So this tool will identify patients that are at risk of going to the ICU or dying. And it runs on GIM patients. It's a predictive model. It sends email alerts, and it runs hourly, and a number of other alerts. So the way the data look and what we did and how this looks on a timeline is there are data that exist at some point in the past. We had a testing set, a validation set, a silent testing phase, which is primarily a technical phase, but we're also looking for validity. Like, now that you've hooked up all these bits and pieces, are you actually still getting the performance you'd expect from a static set of data? And once we cross that line and put it into people's hands, we're in the operationalization phase. So now that people are using it, there is an intervention to help prevent deterioration. So what happens there? This slide does not look correct. Okay, let's see if we can make it work. So what will happen is you have cases of deterioration or no deterioration, and you have alerts that are interventions and alerts, no alert and no intervention. And it feels very easy when there's deterioration or an alert to know your true positives, false positives, and all that. But there is one case that is missing. Oh, thank you that I can see this. Okay, that's awesome. There is a condition where there are true positives, and that is there is no deterioration because someone intervened, which now causes all sorts of problems for us because we fundamentally changed the labels that we have going forward. This makes it a challenge to monitor things, so our performance is technically going to drop, and what we don't know is how much should it drop before we think, oh, there's a problem, or this is in the acceptable boundary of intervention effect. Likewise, this creates a problem for us in the future for any sort of tools that we want to build on the same data, and in fact, any sort of attempts to retrain these data. We have to be very cautious because some of the labels now are fuzzy. So I'm going to introduce a second tool with a comparable timeline. We have a tool called Reward AI, which is meant to identify patients at risk of bleeding. It runs daily, not hourly. runs on the same patients, and has all the same users, or almost all the same users as ChartWatch. So the timeline for this looks a little bit similar, but moved up. The training data comes from mostly that period before ChartWatch actually launched. The testing, validation, and silent data, fortunately, was in a post-ChartWatch deployment time, where we could see the effects here, and performance looked just fine in these stages, especially the silent stage. That one is critical to know that once you hook everything up, things still look good. Then we launched Reward AI, and we have now two separate tools, at least two tools, that have interventions associated with them. So what we've done now is created an even bigger problem for ourselves. These patients have a number of models running with interventions, and we are fundamentally changing what the labels are. Anytime you have an intervention, anytime you prevented something, we are changing what we have. And this is really interesting in this particular case because Reward AI, as a bleed detection tool, also has potential downstream effects. If you miss the bleed, it's possible someone goes to the ICU, or it's possible someone dies, which means this is an indirect way of doing possibly the same intervention as ChartWatch. So we now have two models kind of intervening in the same way, where we end up with race conditions. If someone comes on at 8 in the morning and they see the Reward AI email and they start to act then, ChartWatch can still go off at 9 and 10 and 11 because it's using data from the entire patient history. It doesn't mean ChartWatch is wrong, but it could give the perception that ChartWatch is telling you something's wrong even though as a clinician you've done something. You have intervened on this patient because something else told you to intervene. So we are having issues of how do you actually monitor this and make sure everything is okay, and frankly, how do you not bother people with multiple models telling them something about the same patients? So this also poses a challenge when it comes to evaluation. Now that we have multiple models working on the same patients and potentially having the same kind of intervention effect, how do we know that these are still working? It's a very fair question of whether Reward AI is in fact working or it's all ChartWatch, or vice versa. These can't necessarily be treated independently when it comes to that evaluation period because we have multiple interventions running at the same time. Finally, on these two EPR prediction tools, we have heard some feedback that it can be difficult to get multiple predictions for the same people on the same patients in different ways. So we're starting to think about how we deliver model results that are on the same patients, the same users in very, very different ways. This can just be high tax on cognitive load. So I'll tell us now about two medical imaging prediction tools. One is an intracranial hemorrhage detection tool. It tells us the type and location of a bleed, and one is a neurosurgical intervention tool. It doesn't tell you anything about where something happens, just that this head CT seems to indicate this person needs urgent intervention. So what happens here is, in the emergency department and medical imaging departments, we have a screen that tells you all the imaging that's kind of happening right now. And when one of these models goes off, you see something like what just went by, a little blue alert will pop up on a patient and tell you, there's something happening here. Start the intervention pathway. There it is. So that is the ICH tool. What we will also see on occasion is that both models will go off, or one model goes off, or neither model goes off. And these are very different tools from ChartWatch and Reward AI in the sense that ChartWatch and Reward AI are scheduled. If you don't see your email for Reward AI at 8 in the morning, you know something's up. If you don't see something on the hour from ChartWatch, you know something's up. However, the difficulty, the technical and sometimes say communication difficulty behind event-driven models like this, is it not working or did it not send an alert? And we've learned this lesson kind of hard way, where some downstream and upstream systems are going offline and it's nothing in our setup. Nothing is wrong with our model, but some system might be offline or someone might have changed something. And there are the cases where you have a whole new set of challenges for event-driven models where you don't know, or as a user, you don't know if it's a negative or something has broken, which has pushed us as a team to really monitor everything. As I said up front, we are monitoring systems that are well outside our purview. So, the return of hemodialysis. One more time for one of our favorite deployments. So the hemodialysis tool, recall that the goal of this was to identify high-risk patients and effectively stop some of the unplanned admissions, so to the emergency department and to inpatient units. Well, by doing that, we are now fundamentally changing the makeup of the emergency department and inpatient units. We have a lot of tools that are running in the emergency department and anywhere else in the hospital. And all of these data are trained on basically a time when these patients, the hemodialysis patients, would have been part of that population. So by having a tool somewhere earlier in the process, we are changing our data distribution, likely changing what our model should expect downstream, which poses a bit of a problem on what do you do now if you introduce a tool that changes something for other tools somewhere in the pipeline. Now, I should say these are all working very well. This is a very small effect, but the more we do, the more we introduce, or the bigger types of intervention will cause bigger problems downstream. So what I haven't really mentioned are a lot of the technical challenges. By having all these things, all these tools in place, there is a lot of higher stress and issues that we face as a data science team. We have on-call. So as I noted, like these things are running around the clock, they're event-driven. If something goes wrong, someone is getting woken up and somebody needs to fix it. This is a big challenge in all fairness. So the responsibility of the team has grown to be responders at all hours and understand an incredible amount of the technology, even across our different sub-teams. So in summary, what we see as successful here, or what is the key to success, are project intake, establishing basically the rules, like how we're going to do this, how we're going to move forward, what kind of effect we're going to expect, and outcomes, the impact, are absolutely necessary to know, does this actually have an impact? Is it doing what it's supposed to do? Is it successful? So the next summarization point is feasibility and maintenance are absolutely the most time-consuming parts. Everything I just showed you, we are maintaining. We've got to keep these things online. If it goes down, we get it back on. If we need to make changes or upgrades, or someone else in the hospital is changing another piece of software, we've got to act. So there is an incredible amount of time that's typically not thought of just to keep these things online. And finally, the introduction of models and more models and more models in different places will have consequences. You're going to change labels, you're going to impact the way data distributions look somewhere else. And very frankly, these things I brought up, do they matter? How big of a problem is this? Kind of putting this out there to everyone here to help figure out, is this really a big deal or is it not? But I think we need to know, we need to find the ways in which to understand if these are in fact a big deal or not. So with that, I want to acknowledge kind of just an obscene amount of people. It takes an extraordinary amount of people all across our organization to get these things in place. So I can't, unfortunately, name every single person here, but there are hundreds of people involved in all that we do. Not just our team, but all of our stakeholders, collaborators, current and past, to really get these things out the door and into people's hands and making patient lives better. So with that, I want to say thank you. Thanks for having me here.